Well, hello, everyone. Thank you for joining us today. My name is Aline Sigler. Also on the line with me today is Mary Sue Gardner. We're going to be co-presenting today, so you'll hear from her in just a little bit. A couple housekeeping items quickly here. If you want to download a copy of the slide deck, you can find that on our training center area of our website. This is where we post the event materials for webinars. We do that about a week, so 5 business days in advance, and we do that on the live events page. This is also where you can find out about and register for upcoming educational events. The recording of this and other live webinars will be on our website as an encore presentation. So we have an encore presentations page also. So anybody who wanted to attend but had a scheduling conflict, so you missed the event, or you want to listen to it again, make sure you heard something or take some notes, depending on the number of events that we have, because we do a lot of events. We have a very full schedule. We normally keep these on our website for about 60 to 90 days. So as new webinars are done, some of the older ones might transition off, just because, and if you go out there, you'll see we do have such a long list. You can also find recordings on our YouTube channel. Use the chat feature today to add any questions that you have related to today's topic. Unfortunately, we can't look at your claims in the system, so anything that's claim specific would need to go to customer service. But if you put it in the chat, we can at least look at it and address it as time permits. Whether you're listening to this live or as an encore, we do hope that you'll take the opportunity to give us your feedback by taking a brief survey. Those surveys give us insight into how we're doing, of course, but also lets us know about the types of education that you want and you need. This disclaimer is here to inform you that we do our very best to give you accurate and complete information, but Medicare being a federal program, it does change sometimes, and so anything that CMS has on their website or that they publish or communicate is, of course, going to take priority over anything that's in the slide deck or that we speak to today, but we do our best there. Finally, CMS does prohibit the recording of this presentation for profit-making purposes. I've already told you that we're recording it, so this is done for you. So there would be no need to do screenshots, things like that, because we're also giving you the slide deck. One more notice here, this is the American Hospital Association National Uniform Billing Committee copyright notice. And so this lets you know that I do have some codes within the presentation, billing codes that we don't own, we don't maintain those, and we're just trying to let you know that as well. Now this list, I know a lot of you are familiar with Medicare, but if we have people on the line that are newer to Medicare, you'll quickly notice that nothing is called by its real name. We have acronyms for everything. And so to save space and to have prevent us from having to spell that out on every slide, we've given you this list here of the ones that we know are included in the presentation or that we know we're going to mention. So we're just giving you this so that you can refer back to it as needed. Our goal with this education is for you to gain a comprehensive understanding of the Medicare interrupted stay policy for skilled nursing facilities, including the criteria that differentiates between a continuation of a previous stay and a new stay. We also want to analyze its impact on the skilled nursing facility assessment schedule and how that impacts reimbursement. So to achieve this goal, we're going to examine the 3-day interruption window. and outline the difference in PPS assessment requirements for both of those. We'll detail the billing procedures and analyze the effect of the policy, what effect that policy has on the variable per diem payments. Throughout the presentation, you'll see we've included some examples involving different interruption durations and patient transitions. So by exploring these scenarios, you'll see how the interrupted stay policy shapes assessment and reimbursement, reinforcing your knowledge of how the policy works. We'll begin our presentation by defining some important terms. Some of you may already be familiar with these, but we do have a variety of roles and experience levels in the audience today. And so we just want to start out by saying, what are these things? And then move into how do we put them into practice. First is the interrupted stay policy. If a patient's discharged from a skilled nursing facility, we lovingly refer to them as SNFs because, of course, we have acronyms for them, and then subsequently is readmitted to that same facility for Medicare Part A covered care, specific rules apply. These rules also apply to patients who drop to a non-skilled level of care, but continue to reside in the skilled nursing facility. In these situations, the patient's return to skilled care is treated as a continuation of the previous stay rather than a new admission. This continuation policy applies if the patient returns to skilled care within 3 calendar days of the discharge from the previous Medicare Part A covered stay. So that interrupted stay, we call it a window. That time frame is what we're focusing on today and how that impacts the patient's stay and your reimbursement. The next term that we need to define is variable per diem. The patient-driven payment model, PDPM, determines the variable per diem, VPD, payment rate individually for each day of the patient's skilled nursing facility stay. It does this by utilizing a variable per diem adjustment factor for several payment components, recognizing that resource utilization changes throughout a patient's stay. The variable per diem accounts for changes in resource utilization over the course of a patient's stay. So it ensures reimbursement aligns more accurately with the intensity of services that you're providing. Because of this, the variable per diem adjusts the per diem payment based on the anticipated needs of the patient at different points in their SNF stay. Will they be needing more therapy and then less therapy, or vice versa, just as an example? The variable per diem schedule significantly impacts the non-therapy ancillary portion of payments in skilled nursing facilities. The non-therapy ancillary is referred to as NTA, and you'll see that at different points within our presentation here. So now let's shift the discussion to exploring the policy's potential outcomes. How did it begin? Section 1888 of the Social Security Act stipulates that Medicare payments made to skilled nursing facilities must be made on a per diem or per day basis, meaning that a payment rate is determined for each day of the patient's stay. CMS implemented the interrupted stay policy with the patient-driven payment model due to the addition of the variable per diem adjustment schedule that never existed prior to PDPM. Specifically, the PDPM provides for an adjustment factor that is applied to certain components and changes the per diem rate over the course of the stay. In this way, under PDPM, the per diem rate for a given day of the SNF PPS stay may be different from the prior day, depending on an adjustment factor that may be applied against the SNF PPS rate connected with the HIPS code. And HIPS stands for Health Insurance Prospective Payment System. So why does this matter? Properly identifying interrupted stays is crucial for accurate billing and avoiding potential financial penalties or overpayments. We want to get it right the first time. We as your MAC do, we know you do as providers. Maybe some of you are MDS coordinators, maybe some of you are billers, maybe some of you are in other roles at your facility, director of nursing, whatever that looks like in your office or your facility. It is crucial for accurate billing, and we want to always avoid those potential financial penalties or overpayments. The cost of doing business is high enough without adding errors to it, and so we want to be proactive about that. Because the variable per diem schedule triples the non-therapy ancillary portion of the payment for the first 3 days of the SNF stay. Because of that, CMS sought to discourage and prevent facilities from discharging and readmitting residents just to reset the variable per diem adjustment schedule and therefore take advantage of the higher NTA payments. We hate to think that there are providers and individuals out there who purposely do this to try to quote unquote game the system, but unfortunately we read about it every day. We read about those cases where there are bad actors who are purposely doing things incorrectly to gain financially. And so this is one of those checks and balances that CMS put in place to try to prevent that. So as a result of the interrupted stay policy, the OBRA and PPS schedules, and I know we haven't talked about those yet, they're no longer aligned when a resident discharges and then returns during the interruption window. And Mary Sue's going to go more in depth and talk more about the assessments in her portion of the webinar. So what are some of these significant outcomes of this policy? The SNF PPS assessment schedule does not restart for an interrupted stay. Assessments continue from where they left off before the interruption. The variable per diem payment schedule does not reset to day one. The physician certification and recertification schedule, which isn't part of this webinar, but it is also part of the SNF coverage criteria for Medicare. That schedule also continues from the previous stay. Finally, a single claim is typically submitted for both stays, prior to the interruption and after, and then new patient assessments are generally not required. How does all of this translate to billing? Well, this slide contains some of the common billing components used by skilled nursing facilities. Not all of them apply to every billing situation, but these are some of the common ones. So if you're just learning, I do want to highlight some of them for you. Occurrence codes indicate when a specific action happened. It's a 2-digit code that identifies an event or an action and includes the date of the event or action. One you might see or use often is the 22, which is the date that active care ended. This signifies the last day of skilled care. Similarly are the occurrence span codes. They also identify a specific event or action, but it has a beginning and an ending date associated with it. Examples include, and this is on every Part A claim, the qualifying hospital stay dates. They're indicated with a 70 occurrence span. A 74 specifies a non-covered level of care or dates when a patient was in a leave of absence, for example. 76 identifies the dates of non-covered care for which the beneficiary is liable for payment. This code is used when a patient's responsible for the cost of care during a period when Medicare does not cover the service, but the provider is allowed to bill the patient. Next, we have value codes. Value codes indicate a specific action with an amount associated with it. It's a 2-digit code, identifies the action, and then there's a quantity of an amount or dollars and cents. 81 is the value code used to report the number of non-covered days within a billing period for an inpatient stay. Last on our list here is revenue code 018X. You may not always see that leading 0, but it means the same thing. Revenue codes identify the specific services or procedures that are provided and that you're billing for. And there are lots of different revenue codes that you may have on your claim. But the one that we want to highlight is the 18X, and it's defined as a leave of absence, days when the patient's not present at midnight, but it's also used to report an interrupted stay. So now what I'd like to do is go over some billing examples to reinforce the concept of the interrupted stay policy. We have 3 different patients that we're going to talk about, and we didn't give them a name, just A, B, C. I'm going to be representing the skilled nursing facility in these scenarios. Patient A is admitted to our facility on June 7th. On June 20th, for whatever reason, they're transferred to and admitted to the hospital across town, where they stay until June 25th when they return to us. So how would we bill the June claim? How would it look when it's sent to Medicare? Well, among other things, it's going to contain bill type 211, since it's the first bill for this patient. The admit date is 6/7/2025, and the dates of service, the from and through dates, will be 6/7 through 6/20. The patient discharge status will be a 02, indicating a discharge to a hospital. So those are just some of the main components of our claim. So would this be considered an interrupted stay? They left and they came back to the same skilled nursing facility, but the patient was out of our facility for more than 3 days. When they return on June 25th, it will be a new admission. The assessment schedule will reset and begin with a new 5-day assessment. The variable per diem is also reset. The readmission begins on day 1 of that variable per diem schedule. Then you'd have a second claim for Medicare for June 25th to June 30th. That would also be a 211 type of bill because it is a new admission. And it's going to have a 30 patient status if I assume that the patient will still be here at the end of the month. Now let's look at our second patient, patient B. This patient's also admitted to our skilled nursing facility on June 7th. We also transferred this patient to the hospital on June 20th. This time, the patient only stayed at the hospital until June 22nd, when they were discharged to a SNF, but not our SNF, but not the one where they were initially. So you'll notice that our key billing elements are the same as patient A. They have the same type of bill, same admission date, same dates of service, and even the same patient status is going to be a 02, indicating a discharge to a hospital. Now, would the interrupted stay policy apply to this patient? No. While the time out of the skilled nursing facility was less than 3 days, it's not an interrupted stay because they did not return to the same skilled nursing facility. Both elements of the policy must apply before it's considered an interrupted stay. So that's just a different example for you. Now let's look at our third patient, patient C. They admitted to our skilled nursing facility on June 7th. On June 20th, they were discharged from Medicare Part A, so they went to a lower level of care, but they remained in our facility. A change in status occurred, and they were brought back to Part A care on June 23rd. This is a situation that I'm sure you see quite often with your patients as they improve and decline in their need for skilled care during their stay. So this is a little bit different situation, but one you might encounter. So how is our billing going to look? Our type of bill is still going to be 211 since it's the first claim of the stay. Admit date is June 7th. This is an interrupted stay since the patient was only gone from Part A for 2 days. Our dates of service will be June 7th through June 30th. We're going to need to include a 74 occurrence span with the dates 6/21 through 6/22. Those are the 2 days that they were not at a Part A level. We're going to use revenue code 180 with 2 units and $0 to show those non-covered days, as well as value code 81 with 2 units or 2 days. We're going to assume the patient continued their stay into July. We don't have any information stating otherwise. So our patient status code will be a 30 probably. Now, as far as the schedule goes for this patient, the assessment schedule and the variable per diem do not reset. They continue from where the patient was prior to that non-covered level of care. This is a classic example of an interrupted stay. So I hope taking those hypothetical situations helped kind of drive home what CMS had in mind and how this might impact you as far as this interrupted stay policy goes. So I want to thank you for your attention there. I'm now going to turn it over to the capable hands of my friend and colleague, Mary Sue, for the remainder of the presentation. So Mary Sue, please go ahead.
Thanks so much, Aline, and thank you guys for joining us. As Aline said, my name is Mary Sue Gardner, and I am actually a registered nurse on the provider outreach and education team. So you guys have a unique situation today in getting the billing component as well as the clinical component of the interrupted stay policy. So we're going to transition now into talking about the interrupted stay and how that affects the assessment schedules and documentation on the next slide. So in determining how the interruption may affect your assessments, we have to first understand if the interruption is in the window. So as Aline stated previously, the interruption window is that 3-day period, and it starts with the calendar day of discharge, and it includes the 2 days immediately following. And we're going to say this a lot because it's important for you to understand what is involved and what in that window means. So if a patient was discharged on Monday, the 2 consecutive days immediately following are Tuesday and Wednesday. So to stay inside that window and consider the stay an interruption, the patient must return to that same SNF by 11:59 p.m. at the end of the 3rd calendar day. So in our example, discharge on a Monday, they would have to return by 11:59 on Wednesday. So anything within that time frame is considered in the window, and it will affect assessment schedules. So as we move on, let's talk about days less than 3 and more than 3 and how they affect the overall assessment. We said that inside this interrupted stay window is that time frame of the 3-day period, starting with discharge and including the 2 following days. If a patient's readmitted to the same facility in less than those 3 consecutive days, they are considered inside the window. And you can consider this a continuation of your stay. Now, you would continue your current assessment schedule from that point of discharge. So if the patient was discharged from Part A on day 17, so day 17 was the last covered SNF day, the payment rate resumes at day 18 upon readmission. The assessment schedule also continues from the date of the Part A discharge. Thus, no new 5-day assessment is required upon subsequent readmission. Although the optional interim payment assessment or IPA may be completed, and that's at your discretion or at the provider's discretion. Also, when the stay is within the window of the interrupted stay, no Part A PPS discharge or over discharge is completed, nor is a 5-day entry tracking record required when the Part A resumes. And some examples of when this may happen. Maybe if the patient leaves the SNF AMA or against medical advice, and then they return to that same SNF to resume treatment within that interrupted stay window. Another example, patient discharges maybe to a psych facility for evaluation and treatment, but again, returns to that same Part A facility to resume their covered Part A services. And again, that's within that interruption window. Another very common one is a patient discharges to an acute care setting for evaluation and treatment due to a change in condition. And then they return again to that same SNF within that window. And then finally, the last most common example that you guys will probably see is like the patient is discharging to an assisted living or private residence with like home health services being anticipated. And then again, something happens for whatever reason, and they return to you and they resume Part A services. And again, that's within the interruption window. So we're going to move on to the next slide, and we're going to talk about the readmission to the same facility or different facility when more than 3 consecutive calendar days happen, and how this again affects your assessment schedule. So in the event that the patient happens to return to the SNF or another SNF, and it has been more than 3 consecutive calendar days, then the resumption of skilled care, that's now considered a new stay. For this reason, in regards to the assessments, the SNF would have to start a new 5-day assessment. So in this case, they're considered outside of that window. Remember, if the patient is readmitted to the same SNF, and it's outside that interruption, or that, the interruption window, or In any instance, when the patient is admitted to a different SNF, regardless of the length of time, then the interrupted stay policy does not apply. So again, if it's outside that window or if it's an admission to a different SNF, then this interrupted stay policy doesn't apply. And then subsequent stay, after that is then considered a new stay. So in such cases, the assessment schedule then resets to day one, and that would necessitate a new 5-day assessment. So let's move on to the next slide, and we're going to talk about lower level of care, more than 3 consecutive days, but less than 30 days. So now if a patient is at a lower level of care, so they went out of Part A and maybe they're still in your facility on Part B services, and that's more than 3 consecutive days, but it's less than 30 days, and they're brought back up to a covered Part A stay, then this is, again, not considered an interrupted stay. Now, I bring this up because certain things can happen here. First, the provider must complete a new assessment, and that needs to be done within 8 days of the through date of that occurrence span code 76 that Aline talked about. So the 76 is used to indicate a period of non-covered care for which the hospital or SNF is permitted to bill the beneficiary. So this code is specifically used when a patient experiences a period of lower level of care in a SNF stay. And it signifies that the Benny is responsible for the changes during the specified dates due to a temporary drop, in that level of care, such as transition to a non-skilled level of care. So I want to bring that up because the patient can come back into that same benefit period, but this would be considered a new assessment. So as we move on to the next slide, a lower level of care more than 30 consecutive days and brought back to covered Part A. So again, if the patient's in a lower level of care and it's more than 30 consecutive days and they're brought back up to a covered Part A stay, if the lower level of care is greater than 30 days, the beneficiary is required to have a new qualifying hospital stay in this case, since it's been greater than 30 days, in order for Medicare to cover that Part A stay and to reestablish that SNF benefit. So on the last slide, we talked about how if it was less than 30 days, they could come up and don't have to have a qualifying hospital stay and still go back into that old benefit period. But in this case, if it's more than 30 days, they have to have a new qualifying hospital stay, and that's the three midnight stay. We usually refer to it like 3 midnight stay in a qualifying hospital. So that would be required. If they were within the 30-day transfer period, again, they, inside of that 30-day transfer period, then they wouldn't need that 3-day qualifying hospital stay. But in this case, since they're outside that 30-day transfer and under that 60-day period of wellness, then a new qualifying hospital stay would be required and a new assessment to reestablish SNF benefits. So I know that's not really part of the interrupted stay, but we wanted to also bring you some information about that lower level of care policy because it goes along with the interrupted stay policy as well. So as we move on to the next slide, we're going to talk about capturing the interrupted stay on the MDS. So how do you do this? So the MDS item set, it's A0310G1. That actually identifies where a resident's discharge from a skilled nursing facility qualifies as an interrupted stay under Medicare's PPS policy. So an interrupted stay occurs, when that resident is discharged from the SNF and then resumes services at the same SNF within 3 consecutive calendar days. And again, we're going to just nail that into your head. In this case, the resident returns within this time frame, and the stay then is considered interrupted, and the resident continues the same PPS stay with no new assessment required. Now, accurately coding of this item is really crucial for determining the correct billing and ensuring that your resident's care is properly documented. So the options of coding this item set are 0, which is no, the discharge did not result in an interrupted stay. 1, which is yes, the discharge did result in an interrupted stay. So an example of this. Perhaps a resident's discharged from a skilled nursing facility to a hospital on August 1st, and then they return to the same SNF on August 3rd. Since the resident's return is within that 3 consecutive calendar days, the MDS coordinator should select code 1 for the item A0310G1. And then they are indicating that this is an interrupted stay if the resident had returned on or after August 4th, they would code a 0 in that case. And then that would indicate that it was not an interrupted stay. So it fell outside that window. It wasn't included in the policy. So you'll want to make sure that you're tracking discharge and reentry dates closely. And you're really maintaining detailed records of all the discharges and reentries to determine if it qualifies as an interrupted stay. This is where you really want to make sure your clinical and your billing teams are really communicating effectively to ensure that the accurate billing is done to avoid any payment errors that Aline talked about. Also, it helps to ensure your staff are accurately trained on how the interrupted stay rules could affect, not only accurate documentation, but accurate billing and coding as well. So as we move on to the next slide, let's talk about an interrupted stay without a discharge from the facility. So there may be times, and there's probably going to be more often than not, when a patient has an interrupted stay and they do not discharge from your facility, but they drop in coverage from a Part A stay. So they remain there, and but the coverage under Part A actually stops. However, for some reason, they then resume Part A services. So why does this happen? Well, it can happen for several reasons, as you all know. Maybe the patient elected into a hospice benefit. But for whatever reason elects back out and they want to continue their skilled care. Another example you may see, and this is probably more often than you want to believe, is the patient refuses to participate in skilled rehabilitation. And maybe skilled rehabilitation is what was actually making them eligible to receive Part A skilled services. So they drop to a lower level of care, and then they realize what the daily cost is going to be for them. And maybe they have that come to Jesus moment and decide that they're going to actually participate and resume skilled Part A services because they don't want to be responsible for the payment, or they didn't realize it was going to be so much, or the family said, gosh, you really need to participate or Medicare's not going to pay. So these are just a few examples of how a patient could have an interrupted stay, but not technically discharged from the facility. Finally, before we move into examples, let's go to the next slide and talk about the actual discharge assessment. So since we're talking about how the interrupted stay affects assessments, I want to discuss the discharge assessment and how that may be affected. So the main differences between the OBRA discharge assessment and the SNF PPS discharge assessment lie in when they are used. The OBRA assessments are for physical discharges from the facility, while the SNF PPS discharge assessments are for the end of Medicare Part A stay within the facility. A PPS, or Prospective Payment System assessment, is specifically tied to Medicare Part A coverage, whereas the OBRA assessment is part of a broader resident assessment, or RAI, resident assessment instrument that's required for all nursing facility residents. Let's break these down a little bit more. So the SNF PPS discharge assessment, the purpose of it, it's used to assess a resident at the end of their Medicare Part A stay, even if they remain in the facility. It's triggered by the end of the Medicare Part A stay. And an example of this is a resident whose Medicare Part A stay ends, but who continues to reside in the facility and receive Medicare benefits, like if they go Part B rehabilitation services. So they would require the SNF PPS discharge assessment. The OBRA discharge assessment, the purpose of that is used when the resident physically leaves the facility, regardless of whether they were receiving Medicare Part A benefits. So it's triggered by the physical discharge from the facility. An example of this is a resident who is receiving Medicare Part A services, and now they're being discharged to home or to another facility. So they would require the OBRA discharge assessment. Now, there is a combined assessment. So if a resident's discharged from the facility on the same day or the day after their Medicare Part A stay ends, the SNF PPS discharge assessment and OBRA discharge assessment may be combined in this case. And again, I bring this up during our interrupted stay because it impacts, the interrupted stay impacts your discharge assessment because it's how it's treated. If it's an interrupted stay, it's actually a continuation of a previous stay, meaning a new 5-day assessment isn't required, but it could actually interrupt or affect discharge assessments. So the assessment schedule and payment rates continue from where they left off before that actual interruption. And again, it really depends on if the interruption was in the window or outside the window. So while the SNF PPS discharge assessment may be waived in cases of an interrupted stay, the OBRA discharge assessment might still be required, especially if the patient was discharged to a hospital or had a lengthy observation stay. So this is why accurate tracking and reporting from your clinical staff and your billing staff is necessary. So as we move on to the next slide, let's take a few minutes to practice what we just learned from a clinical perspective. So on the next slide, let's start with question 1. And I'm going to use some of the same examples that Aline used previously, but we're going to talk about it from an assessment factor. So in this case, do you need a new 5-day assessment? So if a patient was admitted to a SNF on June 7th and then admitted to the hospital on June 20th and returns to the same SNF on June 25th, would they need a new 5-day assessment? In this case, the patient was actually gone for 5 days. So this is not inside the interrupted stay window. Therefore, it would be considered a new stay at the SNF, and a new 5-day assessment would be required. So as we move on to question 2, do you need a new 5-day assessment in this case? The patient is admitted to the SNF on 6/7. Then they leave and are admitted to the hospital on 6/20. The patient then goes to a different SNF on 6/22. So in this case, although the time frames under that 3 days, the patient was not admitted back to the original SNF. Therefore, it is considered a new stay. The assessment schedule in this case would also reset, and a new 5-day assessment would be required by the new SNF. So on the next slide, we're going to look at question 3. So do you need a new 5-day assessment in this case? The patient's admitted to the SNF on 6/7. They go to the hospital on 6/20. They return to the same SNF on 6/22. In this case, the interruption is inside the window. So this is considered a continuation of the previous stay. So no PPS assessment in this case is required. Now, the IPA, on the other hand, is an optional assessment, and you can complete the IPA assessment. So as we move on to question 4, let's shift gears slightly and discuss if you need a PPS or OBRA discharge assessment. So this patient discharges from Medicare Part A stay, and then they remain in the facility. They resume Part A within that interrupted stay window. Remember, if the interruption is inside the window, the stay is considered to be interrupted and not ended. So the PPS discharge in this case is not required. OBRA regulations require a discharge assessment when the resident leaves the facility. So this part of the interrupted stay policy and in this part of the interrupted stay policy, no PPS discharge or OBRA discharge is completed, as this is considered a continuation of stay. So therefore, no new 5-day assessment would be required either. All right, as we move on to question 5, do you need a PPS or OBRA in this case? So in this case, the patient actually discharges from Part A. They leave the facility and they resume Part A within the 3-day interruption window. So they're within their window, they're coming back to the same SNF, but they actually discharged. In this case, the PPS discharge is not required because they are within the window. The OBRA would be required because they physically left the facility. And an entry tracking record is required on re-entry. So we have that documentation to show, their re-entry and what went on. But no new 5-day assessment is required because, again, this is considered a continuation of the stay. So moving on to question 6. In this example, the patient's discharged from a Part A, they remain in the facility, and they resume Part A after the 3-day interruption window, but before 30 days. So this would not meet the policy requirements of an interrupted stay. A Part A PPS discharge is required. A 5-day assessment is also required as long as that resumption of Part A occurs within that 30-day window allowed by Medicare. Remember, if it's beyond 30 days, the patient in that case would need a new qualifying hospital stay. So then our final question, question 7, PPS or OBRA discharge. If a patient discharges and leaves the Part A facility and does not resume Part A within that 3-day window, and what assessments are then needed? So again, this is not an interrupted stay. Both Part A, PPS discharge, and OBRA discharge are both required and may be combined. Any return to the facility in this instance would be considered a new entry. That means that an entry tracking record, OBRA admission, and/or 5-day assessment would be required. So that takes us to the end of these examples and the formal presentation. So as we move on to the next slide, I just want to point out before I look over at the chat for any questions that have come in, I wanted to point out all the different resources that are available for you. Aline and I have listed, a lot of resources that I do encourage you to go out and take a look at, especially those, from the PDPM model fact sheet that specifically talk about the interrupted stay policy and the variable per diem adjustment. I'm quite tongue-tied this morning. Okay, so as we move on to the next slide, I want to pause here and I'm going to ask Aline if there are any questions that have come into the chat that I may have missed at this point.
Mary Sue, since I'm sharing the presentation, I did not see any come into the chat, but you might want to double check and look.
All right, just scrolling through. I'm not seeing any at this time. So I'm going to go ahead and move on in the interest of time. But if you have something, I can then pause again and, re-go over that if something comes in. So I wanted to give a reminder about the skilled nursing facility revalidation. So this slide's not in your handouts, but Aline and I included it because we wanted to make sure you're aware and ask that you pass this information on to your facility or your business office. It may not personally pertain to you and your role, but it does pertain to your facility. So in October of 2024, MACs began sending out off-cycle revalidation requests to all skilled nursing facilities due to reporting changes on the CMS 855A enrollment application. So the submission deadline was originally, it's been changed a couple times, and our last one was August 1st. But now CMS has extended that to January 1st of 2026. And that may seem like a long way off, but it will be here before you know it. To avoid interruptions in your Medicare payments, facilities need to do this. This is not optional. This is a required revalidation. So we are pleading with our skilled nursing facilities not to wait until the last minute to send those. We're expecting to receive a ton all at once, and that means it's going to take time to get them all processed. So please try to avoid sending them at the last minute because we want to avoid those delays if possible. If your facility has already completed this task, thank you for doing that. We appreciate it. We apologize that you have to listen to this announcement again, but there are a lot of skilled nursing facilities who have not done that. So please get in touch with your business office. Let them know that this is not optional, that they do have to complete the skilled nursing facility revalidation. Moving on, let's talk about what happens next. In about 4 minutes, you are going to get an email if you signed on to this webinar, if you logged in via computer. So this email also contains your certificate of achievement. And if you wanted to take that to your credentialing bodies and ask for CEUs in regards to this. So the information is at the bottom of the email that you're going to get, and it contains the information about the certificate of achievement and how many contact hours you are eligible for. So as we move on to the next slide, follow-up questions. If you think of any questions regarding this event, email those to us. On your screen right here, wps.gha.education@wpsic.com. That is our email address for provider outreach and education. And you can send questions and put SNF interrupted stay in the subject line. Send those to us within the next week. Please don't send anything that contains any PHI or PII. If your question is claim specific, those need to go to customer service. Aline and I do not have access to the billing world, the billing systems, the this system, so we cannot look any of that up. So claim specific questions do need to go back to customer service. As we move on, as Aline stated at the start of this presentation, we value your opinion. We want to hear from you on how we did on this event. So CMS requires all MACs to give surveys out on each event that they do. This survey only takes a few minutes to complete, and that's why we want to give you the opportunity to do it now, while there's still a couple minutes left in the time that you've allotted for today's event. It's not only your opportunity to tell CMS and to tell WPS what you thought about Aline and I in this type of combined event where we brought you billing information and clinical information, but it's also your opportunity to say what else you need. Give us the information of what other kinds of seminars would help in your day-to-day work. So we do encourage you to take those surveys and let us know what you think, and let us know what other kind of educational events that you need. So as we move on, based on those surveys, we do want to hear from you. We're committed to making those changes. We're committed to looking at those suggestions that you put in the survey. So based on the survey comments, a few things that we have changed and made easier for our providers is we've now added chapters to our YouTube. So before Aline and I post this event in YouTube as an encore, we're going to actually go through and mark the chapters. So that if you want to just go to documentation section, you can just go to documentation. If you want to listen to just Aline's portion, or you want to rewind to that, you can hit that chapter and back up. We've also started adding training indicators to our event advertisement. So it makes it a little easier to know if this event is going to be all billing, all clinical, a combination of billing and clinical, if it'll focus on documentation, if it'll focus on processing through the database, et cetera. So we do hear you. We are making those changes. So that's really why we encourage you to take those surveys as well. So on the next slide, one thing I want to talk to you about is starting on August 4th, and that's just coming in a couple days now, the Provider Contact Center, or PCC, will handle only one MPI or PTAN combination per call. And that's to improve efficiency and reduce wait times for everyone. So if you need assistance with multiple combinations, please call separately for each of those. And for more information, please refer to the WPS News and Update article on provider change for customer service. And a link to that article is going to be provided in the chat for you. And then finally, on behalf of Aline and myself, as well as Medical Review and all of Provider Outreach and Education, we want to thank you for your participation in today's event. So this concludes our webinar, and you may now disconnect.
Thanks, everyone. Have a great day.